So. Yeah, but she's.
Which 2 days?
She's on Thursday, Friday, to actually explore Boston.
You see his slides?
Yeah.
I'll show you from.
Good morning. So the first patient is 77-year-old male, status post fall, found to have this C1 posterior arch fracture as well as a type 2 dens fracture. Of note, he had a previous C3 through 7A CDF at an outside hospital. He was sensory motor intact, he had no upper motor neuron signs. He was placed into a hard collar. An MRI was ordered, which he went to and then decided that he no longer wanted it. And he ultimately wanted to follow up with his primary surgeon. Next patient is the 81-year-old female, status post fall with a left distal radius and ulna fracture. No other past medical history, neurovascularly intact, and then they were closed reduced and put into a sugar tongue splint. And the last patient is a 62-year-old female, status post MBC with this L1 compression fracture, and then L2 through 3 transverse process fractures. They also had a sternum fracture, ribs 3 through 8, and then a past medical history of asthma and sickle cell. They were neurovascularly intact. They were made weight variance tolerated with no restrictions.
Morning. First patient's a 14-year-old male, so that's his football injury with his left long finger, P2 fracture. He was neurovascularly intact and placed into a splint in about 30 degrees of flexion. An 11-year-old male, so that's supposed to fall from a bicycle with a left distal third both bone forearm fracture. He was neurovascularly intact, closed reduced and placed into a sugar tongue splint. Next one is a 10-year-old female status post fall while cheerleading, a right both bone forearm fracture. She was neurovascularly intact, closed reduced and placed into a sugar tongue splint. This is a 3-year-old female status post fall down steps with a left clavicle fracture. Of note, she also suffered a calvarium fracture that neurosurgery was consulted for and managed conservatively. She was neurovascularly intact and placed into a sling. This was a 13-year-old male status post fall while playing basketball with a displaced left tibial tubercle fracture. He was neurovascularly intact and taken the next day for a tibial tubercle ORF. This is a 15-year-old male status post dirt bike injury with a right open Salter-Harris 2 distal tibia and fibula fracture. He was given ANSEP and tetanus, provisionally washed out and splinted, and was taken first case in the morning for a right ankle IND and ORIF. He was then placed into a bivalve long leg cast and made that weight bearing.
So what are you worried about with that fracture?
Say that again?
What are you worried about with that fracture?
I mean, he's 15. Obviously, his spices are still open. I don't think there's his spices is going to close. We'll probably get no more growth from that. Other things, I mean, open fractures. You're worried about. There's a low infection risk. I'm not sure what else.
Yeah, definitely infection, of course. But yeah, so we've studied this, not me, but this has been studied here at this institution in terms of growth arrest. So let's say he was 13 and he had this fracture.
Yeah, so if he was 13, you get about 5 millimeters per year from the distal tibia. Then you'd have about 3 years left to grow if he's a male. So you would get some growth arrest and maybe looking at like 1.5 centimeters of potential leg length discrepancy, but certainly would be more of a concern if he was a little younger.
Agreed. And one of the, yes, so good answer. And then one of the other things I took away from the study here at this institution was that the number of reductions matters. So you want, if you are going to reduce, if this wasn't open, if you were going to reduce it definitively, you get one good attempt really there before you start causing problems. So
Yeah.
you want to get the proper sedation and do it in the proper setting and get a good reduction. If there's any PD pods in the office, in the audience, please, correct me if I'm wrong, but my understanding is you get one good attempt at that.
Yeah,
John?
certainly. That's the, whenever we see these and they're closed in the emergency department, we make sure that we get, adequate sedation and you really try to nail it on your first try.
How big was the opening?
It was about 2 centimeters anteromedially.
And it was a dirt bike, you said?
Yeah,
Is that a low velocity or high velocity type of an injury?
I would say high velocity, probably, type 3 by mechanism, I guess, if you consider the dirt bike high energy.
So it's a 3A?
Yeah.
And how long between the injury and the time that you washed it out?
So he was transferred from Capitol Health in the evening. He was given ANSEF at the time at the outside hospital. The transfer center actually never told us it was open, but it was within 12 hours of the injury that he was taken to the OR.
You said you took it the next morning.
Correct. So it happened at night. He was, it happened, I think, around like 6 or 7 p.m. So he was taken, it was right around the 12-hour mark. We took it right at 6:30.
I mean, there's no evidence to support, that except so there was a recent systematic review about these real mangling open fractures. And this is maybe one of them, but there's no definitive evidence to say that taking these to the OR within any certain point of time really matters. And I think that most of these, the standard of care is definitely, I think what you did is definitely within standard of care. But within 24, I think is the absolute limit that people would say.
As far as growth goes at that distal physis, it's probably less than 5 millimeters a year. It's probably more like 3 to 4 millimeters a year. And as far as the repercussions of that in an adolescent, limb length discrepancy is not on the radar as much as angular deformity. So when you watch these every 4 to 6 months after internal fixation, you're looking for angular partial growth arrest, not complete growth arrest. Or asymmetric growth arrest between the fibula and the tibia, causing an angular deformity of the ankle. So limb length discrepancy is almost never a complication, but asymmetric growth arrest and angular asymmetric growth is a probability in about 15% of these kids.
Is there ever
Joe,
any
can that be done with a-
injury with these?
I'm sorry, there were 2 questions. What?
Saying, there was an adult with a high fibula, you're worried about syndesmosis. Does that happen in kids? I mean, I don't know. I'm asking.
Oh, I guess, yeah, I'm not a syndesmosis expert. You guys see all those injuries. And I'm sure the syndesmosis gets affected just as much as in adults, but for kids, you're going to immobilize this kid. You're not worried about early range of motion in adolescents and children like you are in adults. So in adults, you're going to be fixing a lot of syndesmosis injuries and not worry about immobilization. A lot of these kids, I'll put them in. I mean, this kid will definitely be in a cast, and sometimes I'll even use a long leg cast in a non-compliant 15-year-old boy who's going to do everything I tell him not to do. So the cast immobilization after these injuries will, treat the syndesmosis if you're not fixing it surgically. But we certainly will immobilize kids a lot differently than we do for adults.
Phil, Tim Letty here. My question was going to be, do you have to have a special study or just a standard x-ray is sufficient to measure for any angular deformity? I mean, obviously a scanogram if you're looking for a leg length, but you don't need to do that every time you monitor that kid, right?
Right. I don't use scanograms to follow limb length discrepancy post-traumatic. I follow them clinically. I think, after a few years of experience, a good pediatric orthopedist can just measure limb lengths clinically, standing on blocks, that's probably the best way to follow limb length discrepancy. To follow angular deformity, asymmetric closure, you can pick it up with just a standing AP radiograph, standing lateral standing lateral radiograph, and I do that every 6 months. And it's pretty easy to do. You get both ankles on the same cassette, and you can see an early closure before you can pick it up clinically. You can pick it up radiographically, and then you can follow them every 4 months. Once you pick it up, on your 6-month X-ray, you can follow them more closely to see if you're going to need to intervene surgically.
Good morning, everyone. First, we have a 10-year-old right-hand dominant 10-year-old male that was fall while playing soccer. Stands right, medial condyle fracture. Was placed in a posterior splint, and we'll discuss surgical management of this here as an outpatient. Next, we have a 68-year-old female. Ground level fall, she stubbed her toe. Sustained this right great toe, metatarsal base fracture. It's intra-articular. She's placed into a posterior splint. She'll follow up for a session of surgical management of this injury. Next is a 72-year-old female, assessed with ground level fall with this left femoral neck fracture. She was sitting in the operating room for cannulated screw fixation. Thank you.
Morning. First patient is a 7-year-old male who fell out of a trampoline park and sustained his right distal fibula and fibula fractures. He was closed, reduced, and placed into a long leg cast at his bivalve. Next patient is a 23-year-old gentleman who fell from the 2nd story when he was cleaning the rooftop. He sustained a T12 burst fracture as well as a left clavicle and ipsilateral left inferior ramus fractures. Here, he was neurovascularly intact. He went for MRI imaging to evaluate the posterior ligamentous complex, which was intact with no significant compression, and he was indicated for TLSO. Next patient is a 40-year-old male who fell on a hike and sustained his left Weber-B ankle fracture that was stress negative on the far right image. He was placed in a short AO. Next patient is a 75-year-old female who fell from standing in her kitchen and sustained this right proximal humerus fracture. Axillary imaging showed that there was no dislocation. She was neurovascularly intact. I did a little closed reduction and she was placed in the sling. Next patient is a 73-year-old female who also fell from standing and had this right proximal humerus fracture. Axillary imaging showing no dislocation, and she was placed into a sling. Next patient is a 28-year-old gentleman who was a pedestrian struck, who sustained this left closed distal radius fracture. He was initially closed, reduced, and placed into a sugar tongue splint in the emergency department and followed up in the office for further management. And he was indicated for a left distal radius open reduction and internal fixation. Next patient is a 17-year-old male who fell at a camp from a few feet off the ground and sustained this right olecranon and radial head fracture. CT imaging was obtained to better delineate the pattern. It showed a comminuted olecranon and radial head. He was neurovascularly intact. And he was taken to the operating room the following day for a right radial head and electron open reaction internal fixation, as well as an LCL repair.
That's a nasty injury. When are you
Yeah.
gonna get that? When are you gonna get that one moving?
So our plan was to splint him for 2 weeks because of the LCL repair. He was very unstable prior to the repair. And then luckily he's young. After 2 weeks, we'll take off the splint and get him moving as soon as possible.
What was unstable?
Everything, it was just like very.
So Anna, what shoulder position do you want to avoid as you start his post-operative rehabilitation?
I'm sorry, what was that?
I said, what shoulder position do you want to avoid when you start his post-operative rehabilitation?
What shoulder position?
Yeah,
Abduction?
yeah, because that stresses the LCL. And I mean, I think your x-rays look great just looking at them quickly, but one thing I've done is I've tried to augment that lateral side. You know, you can either, if it's really unstable, you can think of your internal joint stabilizer. You can also think of, you know, some sort of suture tape just as extra protection, especially as you start moving, because the last thing you want is an unstable elbow and have to go back.
Thank you.
So you can't, well, you actually, you technically can, but it's very bulky and it's tough to stack the IJS on that plate. So that's definitely a great idea, because at 17, he's, you know, his bone was great, but he's done growing. So it's more of an adult injury. But yeah, this is going to be a real challenge to rehab. So tough.
That patient is a 6-year-old female, status both fall with the right distal radius fracture. Close reduced, placed in a sugar constant.
Morning. First patient's a 3-year-old male who fell on the steps, sustained an isolated right ulnar shaft fracture. He was placed in a long arm bivalve cast. He's a 12-year-old male who fell playing football as a defensive end, sustained a right sulfur-Harris distal radius fracture. He was closed reduced and placed into a shoulder consequence. It's a 17-year-old female who sustained a collision with another player while playing soccer and has this right non-displaced proximal tibia fracture. She was placed into a bulking knee immobilizer. This is a 62-year-old male who fell playing basketball, sustained his left Montasia variant fracture. Initially attempted a closed reduction in the ER, placed into a posterior splint, and taken for a left ulna ORIF. This is a 69-year-old male who was positioning for an MRI brain, and when he lifted his leg, sustained his left hip lesser stroke fracture, periprosthetic. He's made protective weight bearing walker.
When did he have his hip done?
This was 15 years ago.
And it was just a spontaneous fracture, just raising his leg. What does that make you worried about?
I'm sorry.
He was just raising his leg and the lesser fracture.
Well, he has a significant amount of osteolysis there, and he actually had a previous incident 2 years ago where he had a similar incident, and I'm imagining that's why his greater trochanter looks abnormal as well. But distally, it seems that everything's well fixed, and didn't feel that there's any indication to prophylactically do anything else for him.
What if somebody came, what if it was a non-prosthetic case, isolated lesser stroke bone?
You asking if I would do anything differently? Or?
What would you work? Was the question Dr. Letty's getting at this? What is that a sign of?
I'm not
Is
sure.
this a metal on metal?
Yeah.
Yeah, the question that I'm getting at doesn't, I mean, to Charlie's point, it's usually something that you would see in a regular hip, but an isolated lesser trope fracture carries with it some connotations.
Okay,
That's that. Primary. So obviously, it's like thick stem, and you have a lot of, you get stress building of the proximal femur. Maybe well, so it's metal on metal. That's just not.
this is a 9-year-old female, Sasso's fall with a right hip intertrachea tear fracture, was taken for a right hip intramedullary nail. This is a 24-year-old male who sustained a fall after a layup on basketball and has the type 3A open left distal tibia and fibula fracture. He underwent a left tibia IND and intramedullary nail. There's a 39-year-old male who fell 15 feet from a ladder and has this right tibia and fibula fracture. Due to the fracture pattern, he was taken for a CT, which showed that it did not extend into the ankle joint. He was then taken for a right tibia IML. There's a 28-year-old male who was reportedly shot 20 times and has for us a right proximal humerus unicortical fracture, right tibia shaft fracture, and a left distal clavicle fracture. Otherwise, he had a diaphragm injury, a liver laceration, kidney laceration, colectomy, and a hemopneumothorax, as well as a retained bullet at T11, for which he's in Asia A.
Question from the last case, if you don't mind, and you might answer this, but what percentage of cases would tell her, and are we doing a study of choice?
I'm sorry, you broke up there. Can you repeat that?
I'm sorry. What I wanted to know was, is there a number for how many suprapatellar nails versus infrapatellar nails we're putting in? And is that number skewed because we're doing a study right now, or is it just dealer's choice?
The vast majority of the tibia nails we do now here are suprapatellar. I don't know of any studies going on that we're doing here. I think it's just because it's been our attendings have found it to be easier. There's less patient positioning issues. There's it's easy to manage the soft tissue, and you're not getting pushed in the wrong direction by the soft tissue. So I think that it's just been felt to be easier to do.
So definitely the majority are suprapatellar.
Mm-hmm. Yep.
As someone who does very few of these, it's a lot easier to do the case suprapatellar. The knee is extended. It's a lot easier to manipulate the fracture and just control everything. So and it's not difficult.
So going back to our polytrauma patient here, this is his right and left shoulder x-rays showing the cortical defect in the proximal humerus on the right side and distal clavicle on the left side. That bullet is directly subcutaneous posterior aspect. This is tibia shaft fracture. He was originally placed into a elongated splint. And then after he was medically optimized, taken a few days later for a tibia IND and intramedullary nail.
Is that an automatic rifle? Shot 20 times.
They said that got shot 20 times, handgun, so maybe it's multiple handguns. But he was just going to church, so.
I mean, 50 Cent only got shot 9 times, so this guy's got a rap career ahead of him.
What's an automatic rifle?
I'd be more concerned about the soft tissue injuries and would want to make sure he's on more antibiotic coverage.
This is a 16-year-old female, syndromic kid, non-verbal, non-ambulatory. Her mom and nursing aide were transferring her in the wheelchair, and her foot got caught in a doorway and twisted. And then they noticed that she was displaying signs of discomfort for that leg, so they took her in for evaluation. She was found to have a distal third tibial shaft fracture. She was put in a short leg AO well padded splint, given her non-ambulatory status. There's a 49-year-old male who slammed his right thumb in a car door, had an open tough fracture. He received ANSEP and tetanus. He had a little bit of exposed bone, so we underwent a revision amp and nail bed repair. Sent out Cathlex. This is a 5-year-old male who was playing Superman and jumped from a couch and hit his right leg. He sustained this proximal tibia fracture. He was put in a long leg bivalve cast. This is an 84-year-old female, status post motor vehicle accident, sustained a left tracheal fracture. You can see best on the lateral imaging. She was just placed in a wrist splint. She was point tender right over her tracheum there, but otherwise no tenderness. This is a 89-year-old female who suffered a ground level fall, has a right LC1 pelvis. She had a history of a fall several years, about 10 years prior, where she had a similar injury. So it looks like she broke the callus there. There's a 97-year-old female who also suffered ground level fall and had a left LC1 pelvis. This is a 10-year-old male who suffered a fall while playing, has a distal both bone forearm fracture. He was seen at an outside institution where they had attempted multiple closed reductions and were unsuccessful. So he was transferred here for a higher level of care. Given the multiple closed reduction attempts with sedation in the previous emergency department, it was decided that he would be taken to the operating room here to undergo a closed reduction under anesthesia. So he was successfully closed reduced and placed in a sugar tongue splint. This is a 57-year-old female who was in a motor vehicle accident. She initially underwent CT imaging of her spine, and it was negative for any obvious osseous pathology. However, when they went to clear her C-collar, she was markedly tender. So they obtained MRIs, which showed these T1, T2, and L1 fractures, as well as the C6, C7 end plate fractures. She was neurovascularly intact, absolutely no deficits, just some tender sulcation over her posterior lower C spine, upper T spine. She was placed in a hard collar and will follow up in office. This is a 79-year-old female who fell at a nursing home. She is very pleasantly demented, doesn't remember what happened, but just complaining of pain in her left shoulder, has a proximal humerus fracture, was given a sling. This is a 10-year-old male who had an injury to his right arm playing football and suffered this plastic deformity injury. He noticed his arm was crooked, and was having pain right over the apex of the bow, so he came in. He was, reduced and put in a sugar tongue splint. This is a 14-year-old female who suffered a fall while playing with a motorized bike. She landed on her left distal radius and had this distal radius fracture. She was closed reduced and put in a sugar tongue splint. There's an 87-year-old male whose wife was pushing him on his rolling scooter when he fell and landed on his left arm. We originally called for this old ulnar styloid fracture. But on imaging, you can see a lucency in his scaphoid here. And he was also point tender in his snuff box. So he was placed in a thumb spica and he'll follow up outpatient. He also was complaining of some shoulder pain and was tender over his biceps tendon, but x-rays were negative and it radiated down his biceps and his forearm. This is a 91-year-old female who had a fall from standing height, mechanical fall, landed on her right wrist, has a distal radius fracture. She was closed, reduced, and put in sugar tongue sponge.
Good morning. First patient writing down a 15-year-old male, assessed with fall, ground level, to the right, type 1, open vocal form fracture. There's nerve action, washed out, splinted in the ER, received ANSEF, take to the operating room for a forearm IND, closed reduction, percutaneous pain with these flexible nails.
You do the IND, you deliver the bone inside of them.
No, so what we did was we just extended the incision about a centimeter and just dissected down to the fracture site or the wash out. We actually deliver the bone through the incision, through the wound, sorry.
Morning. This patient is 50-year female, status was fall with right ankle fracture dislocation. Patient was initially close to this and splinted. She was very swollen, so X-fix was applied and patient was sent for CAT scan. After 2 weeks, the patient was taken back to the OR for right ankle ORIF. Next patient is 23-year-old male, status was fall while playing basketball. Who was diagnosed with left tibial plantar fracture, split depression type. He was taken to the OR for left tibia open reduction and fixation. Next patient is 88-year-old female, status was fall with a non-displaced left femoral neck fracture. Patient was taken to the OR for left hip kynolytic screws. Next patient is 96-year-old female, status was fall with right femoral neck fracture. Patient was taken to the OR for right hip kynolytic screws. Thank you. That's it. Thank you.